Hello, everyone, and thank you for joining us for today's webinar titled Cardiac Telemetry, Continuous Vital Signs Monitoring in Post-Acute Care, Best Practices and Real-World Insights. Grace, you can advance the slide. Thanks. My name is Joanne Yao, and I am the Vice President of Marketing with Vios Medical. Today, we're excited to bring you perspectives from three outstanding leaders in post-acute clinical practice. Kayla Hollborn, Telemetry Monitoring Director at Momentum at South Bay for Rehabilitation and Nursing. Don Wozniak, Regional Director of Clinical Services with Mission Health Communities. And Cindy Froning, Executive Director of NADONA. A few quick logistics before we get started. So our agenda will begin with presentations from Don and Kayla, followed by a panel discussion and Q&A session with all three speakers. All participants are on mute to ensure sound quality. So please feel free to type your questions into the chat panel at any time during the program. We will answer as many questions as possible during the Q&A panel discussion, and any questions that we don't have time to answer will receive a follow-up after the session. Now I'd like to introduce our speakers. Kayla Hollborn practices physical therapy and serves as the Telemetry Monitoring Director for Momentum at South Bay for Rehabilitation and Nursing in New York. Her leadership of the Vios Monitoring Telemetry Program was instrumental in Momentum earning the Bronze Award in the Quality category of the 2022 McKnight's Tech Awards for the application of the technology. Don Wozniak serves as the Regional Director of Clinical Services for Mission Health Communities. She oversees long-term care and assisted living facilities in Minnesota, Wisconsin, and Tennessee, focusing on quality improvement and best practices to achieve optimal outcomes for patients and residents. So thank you all again for joining us today. I will turn it over to Don to get started.
Good afternoon. My name is Dawn Wozniak, and I'm a registered nurse. And in the state of Minnesota, on the first Wednesday of the month at 1 o'clock Central Standard Time, we do our emergency systems testing. So in the background here, you're going to hear our sirens going off. And I apologize for that and didn't realize or didn't correlate that with this is the first Wednesday of the month and it's 1 o'clock. And I am a Minnesotan, so I should know what to expect. I believe they do 3 whistle blows, and this should be their final whistle blow, and then I'll get started. Just waiting for it to wind down here. And I'd say they're about done. So I'm here today to talk to you about the cardiac patients that we take care of in our post-acute care. So there's a variety of areas that I want to cover. So I am going to start with why cardiac patients are discharged to post-acute care instead of discharging to home. So the average age of a cardiac insult or issue for men is 65 and women is 72. And that is right there within the population that we traditionally take care of in post-acute care. The reasons that they end up coming to post-acute care versus being able to discharge home are varied. One of the primary reasons is there's definitely a functional decline that can happen with hospitalization. So these folks, the typical hospital stay is going to be 3 to 7 days. During that time frame, they may suffer from what's called a post-hospital syndrome, which is a series of symptoms that can last up to 7 weeks and make them more vulnerable. Some of the common issues that are seen include fatigue, weakness, poor mobility, mental fog, and emotional distress. These folks also have a high risk of hospitalization after discharge. So we're trying to help decrease that return to hospital piece. 20% of the folks will be rehospitalized. 30% will experience a new difficulty with an ADL after this hospitalization, and approximately 14% of these patients will experience a fall within weeks of discharge. So, in the post-acute care arena, those are some things that we are going to care plan and try to mitigate that risk of rehospitalization, get interventions in place to prevent falls, and keep that from happening as well. These folks also have a need for closer monitoring. Medication compliance, again, if we've got mental fog, if we've got some weakness or confusion, fatigue, the interactions with these new medications that they may be started on, we're going to be monitoring for any of those. Fluid balance, symptom tracking, monitoring labs that the physician will order, and doing any diagnostic testing. When you look at coming to a post-acute care versus going home, there are some definite gaps there that lead them to coming with us. And most of the time, it's related to insufficient caregiver support. The person might be single, they may have a spouse that has disabilities or has some physical limitations to be able to provide that support. Next slide, please. Some of the challenges that we have in managing our cardiac patients in post-acute care include in the background, we are balancing multiple comorbidities. So these folks may have diabetes, and we're dealing with blood sugars and monitoring that and adjusting insulins, hypertension, cognitive impairment, arthritis and pain management with that, COPD, and any respiratory management with that. And I think probably a bigger one that we frequently see, at least in our market, is delirium. Some of the things I think that we can do better in the post-acute setting that creates an issue are inconsistent monitoring and assessments. I believe there's really a need for some standardized protocols and additional staff education for cardiac care. An additional challenge is polypharmacy. When you've got new medications that are coming on board with the hospitalization, we see frequent dose adjustments depending upon the resident's response to those medications. And there's also an increased risk of adverse interactions when you add more medications. Probably one of the most challenging pieces, I believe, of this are residents with the cardiac insult who have cognitive issues. Delirium affects 15 to 50% of the elderly who have a post-cardiac event. That delirium leads to a variety of issues to try to manage. You can end up with problems with non-adherence to medications because the meds don't look like the medications that they had taken before the hospitalization. It can be difficult to get them mobilized in therapy, which is a huge part of the rehabilitation post-cardiac event. The other thing that we work at managing is trying to prevent secondary complications, avoiding skin injuries, trauma from falls, and nutritional compromise. Skin injuries, if we're struggling with getting folks to mobilize post-event, that puts them at higher risk for skin injury. Certainly, if there's a new onset of incontinence, also puts them at a high risk for skin injuries. We talked a bit about the falls percentage and those at risk for falls. So trauma from falls is something that we're going to work to prevent. And then I think nutritional compromise, our meal times may not match up with what they're used to. And certainly in most instances, I think people will agree that the food doesn't taste the same as the food that you make at home. So that becomes an issue as well. Next, thank you. So current guidelines for managing cardiac patients in post-acute care. As I was researching this and looking at what we do in the facilities that I help support, I really found that there are very few formal standardized guidelines. What I did find was that most parameters come from the discharging physician or hospital. So you're going to see things, or at least we see things very individualized directly related to what type of cardiac event that they had, and the resident status before that. So we may have individualized instructions regarding weight targets, activity limitations, blood pressure controls, diet and fluid restrictions. And again, as I was looking at this and researching this, the broad best practices that I found were training and protocols, including staff education, thorough assessments, and rapid intervention, early mobilization, and I can't stress that enough. That was one of the top things I saw in multiple places as I was researching. Psychosocial support, addressing anxiety and depression, and connecting people to resources. Um, it seems to me with the patients that I work with and deal with and get reported back from our TCUs is that anxiety and depression seems to run a bit higher in the cardiac patient than in some other health insults. So we are fortunate that there are a lot of resources, at least in the market that I serve, for psychosocial services, to be able to have a therapist who will come in and talk to them and have psychiatry as needed. Then the other piece is patient education. I believe that when you educate the patient so that they can take control of of things in their life, whether it's lifestyle changes, medication adherence, symptom recognition, and risk factor control. Those are all things that when the patient has control, I believe you get better adherence. So, for example, on lifestyle changes, we may be looking at dietary changes and having them be involved and understanding the reason behind those potential dietary changes, medication adherence, when they know why I need to take this and they've got a good understanding of it. Symptom recognition. So it's very important for them to be able to recognize some of those symptoms and then know when they need to notify a provider or when they need to call 911. Symptoms might be pain, edema, shortness of breath, certainly chest pain. So going through and making sure that they have a good understanding of those symptoms and are able to recognize those symptoms before discharge. And then risk factor control, controlling hypertension, utilization of blood pressure meds, cholesterol, statin meds, dietary changes, and those types of things as well. So let's talk about cardiac monitoring and specifically why we should consider cardiac monitoring. Our building, one of my buildings, is considering the cardiac monitoring. And so these are some of the reasons that we're looking at it. One is enhanced staff responsiveness. So I feel like the more and the earlier that you have information in regard to changes in condition, particularly those that might be asymptomatic, the quicker and better we are able to respond to those. When you have continuous monitoring, it supports faster medication adjustments, can help lower readmission rates, and leads to an overall improved patient health and recovery. Increased patient confidence. This is one I think that people may underestimate. When you have a patient who's coming from, say, a cardiac step-down unit where they've been on telemetry and the day of discharge comes and the nurse is going through the discharge instructions and they're being, the ECG monitoring leads are being removed. And then you come to a post-acute setting and the nurse comes in and checks your vital signs every 4 hours. That's a significant change in the level of care, or at least perceived level of care that they're seeing. So in order for us to be able to have this type of monitoring and for us to be able to explain that monitoring them and to them and explain to them what this is going to do for them and how this allows us to monitor and respond to those changes is a big deal for reducing anxiety and building trust with the patients and families and the care team. So I'm really excited about that piece as well. And then we're running a business and I'm a nurse, and the primary thing that matters to me is the patient and the patient outcomes, but we're also running a business and being fiscally responsible. So I firmly believe that partnering with specialty providers adds value to our services. It can support census growth, enhance our reputation, and our capabilities. So allows us to take care of different patients and more patients. So the last part of my presentation are some things and considerations for selecting a cardiac monitoring and technology partner. You know, when we look at the pros and cons and things to think about as we're working through our plan, certainly one of the areas that we were looked at was cost and resource efficiency and concerns about hardware, the maintenance of the hardware. Would that strain our resources with that? So one of the potential solutions is making sure that you're using a scalable, cost-effective system with streamlined deployment and ongoing support. So trying to take that out of where we look at hardware things as being part of our IT department or potentially part of our maintenance department. Instead, that goes to the vendor, and we rely on the vendor for that. When I was discussing this potential of this new program being rolled out with our medical director, one of the first things that he said to me was that this type of monitoring gets noisy. And what he meant by that was alarm management, and specifically false alarms and worrying about alarm fatigue consuming staff time. So again, a solution for that is making sure that the partner you choose has tech with strong filters, smart alarms, and clear protocols to minimize the false alarms. Clinical staff training and clinical support is another area. So making sure that our folks know rhythm recognition, electrode placement, and the prep required for the placement, and consistent training for that. So again, a solution is to work with a partner that offers comprehensive onboarding, ongoing education, because we do have turnover with our nursing staff, are some best practices for resources. Signal quality and data integration, movement, poor prep or disconnected leads reduce the data quality, and your EMR integration is inconsistent. So again, we're having reliable hardware with strong connectivity, stable signal quality, and smooth EMR integration is a way to deal with that particular potential issue. And then patient comfort and compliance. Traditional wires hinder mobility, hygiene, and sleep. So having a patient-friendly design that supports daily activities while maintaining monitoring accuracy is important. So that concludes my portion. So I'd like to turn it over to Kayla, who will be talking about the system that they're using.
Hey everyone, my name is Kayla Hollborn and I am a physical therapist assistant that works at Momentum at South Bay. So a little bit about Momentum. We're a short-term and long-term facility. We have 160 beds located in East Islip, New York. We are a CMS 5-star rated facility, and we are also rated one of America's best nursing homes, along with, like Joanne had said, a recipient of the 2022 McKnight Tech Awards. So we had realized that we definitely had a monitoring challenge here. We relied heavily on the standard 12-lead ECG, which I'm sure, as everyone knows, only gives you a snapshot in time. It's not something that is continuous. We realized we lacked real-time data to help support our interventions here. So we were finding that we would miss early warning signs on patients, whether things were asymptomatic. We also found that we were having to send a lot of our cardiopulmonary patients out more to the hospital than we would have liked. So it did become clear to us that we wanted to enhance our cardiopulmonary program here, and that we needed something a little bit more that helped us focus on improving patient outcomes while also supporting our clinical staff. So really, we wanted to elevate the quality of care through smart technology to help us. So our monitoring solution was to do cardiac continuous. So it goes with Vios, it goes beyond just continuous monitoring. They also have a 24/7 external oversight, which the remote technicians assist with. It also adds a critical layer of support for our program. Our clinical team is very busy. They're on the go all day long. So having this oversight has not only freed them up by not having to do manual checks all day long, especially for the higher acuity patients, but it also allowed the team to provide higher acuity care for patients. So with the continuous monitoring, we were able to provide hospital-grade cardiac telemetry, which gave us real-time access at the bedside. So this allowed our nursing staff to be more proactive when a patient experiences a cardiac event, whether it be something minor or unfortunately something like a cardiac arrest. So with the 24/7 remote monitoring, not only does our clinical staff monitor the central monitoring station and the bedside monitors, but with the certified ECG technicians, they alert us when anything pops up, whether a patient newly went into AFib, or even if a lead popped off during, for us, it would be during like ADL care if on accident. So our interventions, our care team responds to all the alarms that happen, and interventions that we put in place help prevent readmissions for us. And of course, moves patients toward recovery while reducing rehospitalizations. So the Vios monitoring system is a chest sensor with the electrode placement as seen. And the chest sensor obviously is on the patient, and then it connects via Bluetooth to the bedside monitor. So the chest sensor and monitor are always with the patient. From there, it goes to a central server and then to the central monitoring station. For us, our central monitoring station is at our nursing core. And through the central server and the central monitoring station is where the outside technicians are able to see every patient that we have on. So our goals for the monitoring program here, so we wanted to provide continuous oversight for our clinically fragile patients. We wanted to enable early detection, which allows us to have rapid intervention. We also wanted to empower our clinical staff to feel confident and supported with their decisions that they're making, both nursing and our medical providers. We also, of course, wanted to support safe, effective care for our cardiopulmonary patients. So for us getting started, we collaborated with our medical director, our cardiology team, our primary care givers that work with us, and of course, our nursing staff. We wanted to ensure that we had the readiness and the capacity to support such a system. This included developing protocols and evaluating medications that we have in-house. In addition, we added access points throughout the facility to enhance our Wi-Fi system. We wanted to make sure that we do not run into any connection issues when bedside monitors are communicating to the central monitoring system. And throughout all that, we gradually integrated Vios telemetry into our workflows, and it has honestly become quite the staple of our cardiac program here. So for us, our monitoring protocol, we review obviously every admission that comes in. Someone that comes in from the hospital with a cardiac diagnosis such as an MSTEMI or new onset of AFib with RVR, they'll go on telemetry for at least 10 to 14 days. Patient that comes in with an extensive cardiac history, we want to be proactive. So they'll most likely be placed on for a minimum of 5 days. In addition, anytime during our patient stay, if a patient is prescribed and needs to go with IV Lasix, they'll be placed on telemetry for the duration of that medication plus 1 day. So we have that extra added oversight. Also, of course, if a patient has a medical decline or significant clinical change, we'll place them on Vios. And then we also started using it when we're trying to titrate residents' oxygen, especially if they were put on oxygen in the hospital and may not necessarily have been on it prior to their hospitalization. So in terms when we discontinue it, it's all based on the patient. We ideally aim for the 10 to 14 or the 5 days, but sometimes we do find that we need to extend the amount of time that they're on cardiac telemetry, not only to benefit the patient, but to also help our clinical staff know exactly what routes we should be taking in terms of protocols. So our workflow integration, the bedside monitors we keep either in the patient's rooms or outside. And our bedside nursing, which is primarily our LPNs, they ensure proper lead placement, that the batteries are charged and don't need to need to be replaced, and that there's continuous signal transmission. They also respond promptly to any of the alarms and communicate the changes with our clinical team and our cardiology team. Our clinical team, so they're monitoring the central monitoring station for all the patients, and they communicate any concerns, alerts with the primary care doctors here and cardiology team. We still like our staff to be ahead of the game, so we make sure that throughout the day everyone is monitoring it, even though we have the 24/7 ECG technicians that oversee it on their end. So we even incorporated the Vios telemetry into our skilled physical and occupational therapy sessions. So we integrated the monitoring because it allows us to give a real-time patient feedback. A lot of times we'll use it, especially when we're trying to titrate from oxygen and go through activities that may deal with perceived exertion, and having the patient sometimes see that visual feedback on the bedside monitor into how they're feeling has really helped through our sessions. It also frees up our therapists by not constantly having to stop and check vitals. And then, of course, we have the remote monitoring service, which is the 24/7 certified ECG technician oversight. They notify us of, again, any alarms, any changes that may happen. So one of the case studies we had was a 99-year-old post-acute cardiac patient. She was admitted for chest pain, hypertensive urgency, and AFib. She had a very complicated cardiac history. So of course, upon admission with our protocol, she was admitted for the 10 to 14 day time frame. So throughout her clinical course, she wound up having persistent tachycardia with her heart rate going upwards of the 150s, and she had blood pressure instability. So because of the Vios, we were able to intervene much quicker. We were able to make any medication changes that were needed to be had. And this was also a patient who came to us on room air, and she started desatting. So we were able to add that oxygen component that Vios has. With being able to have that quick insight to what is going on without the manual checks, we were able to intervene much quicker, provide better care, and ultimately we were able to not have to send her back to the hospital, which of course we want happy patients, and we don't want to have to transfer her to the hospital. Another case study we had was an 82-year-old therapy patient. So he was admitted for orthostatic hypertension, weakness, syncope, status post-fall, and again, another one that had a very extensive cardiac history. Therefore, he was enrolled onto telemetry upon admission for that 10 to 14 day time period. His COPD was very bad, and it was extremely hard for him to maintain oxygen levels appropriately during therapy. So we were able to, again, with the bedside monitor, incorporate it into our therapy sessions. This helped not only educate the patient on their perceived exertion and their breathing levels with certain activities, but we were able to monitor much closely, and it also gave our therapists that added support during their sessions to appropriately cater to the patient's needs. So patient care, rehabilitation, and benefits. So Vios continuous monitoring allows us to have real-time arrhythmia detection. It allows us to support certain medications like IV Lasix. Not a lot of places feel confident administering that type of medication. However, here, because we have Vios, our team feels very confident. And it enables us to treat higher acuity patients more confidently in the rehab setting and in the nursing setting at Momentum. So we improve patient care through the continuous monitoring. It also gives our patients and their families peace of mind. We see a lot of patients that come here that at first may not necessarily want to be placed on a hot monitor again after they were just had one on for several days in the hospital. But in the end, they're always very thankful for it and happy that they have that extra oversight. It gives our clinical team to be able to monitor patients without being at bedside. Again, we all live in a very busy world in healthcare, and it's impossible to stay with one patient constantly. So this helps our team be more mobile and continuing giving that higher end oversight over our higher acuity patients. It also allows our staff to be more flexible. And in addition, it also allows our patients to be mobile. So in our setting, we have patients that leave their rooms to go visit families, to go to recreational activities, if they want to go outside on the patio on a nice day. Vios goes with them. And while it's with them, we're still able to monitor them. So it's not confining the patients to their rooms. They're able to be mobile and enjoy their stay. So tips for success. Definitely ensure that you have a strong Wi-Fi coverage. So for us, we had to add extra access points. We had an issue sometimes with clinical staff not being by the phone when the technicians called because they were busy dealing with patients and families. So we wound up having our nursing secretary assist our clinical team with answering calls, and she makes the appropriate clinical team members aware when a call does come in. And then one of probably the bigger things that definitely helped us was, when we first started, our central monitoring station was just located at our second floor core. We're a 2-level building. Because the central monitoring station is browser-based, we now have it on several computers throughout the facility. So now we have more oversight on different levels of the floors, and we even have it in our rehab gym. So one of the biggest takeaways for us here was bridging the gap between hospital level care and community-based care. We were able to safely manage patients that not necessarily are medically and physically appropriate to attend an outpatient cardiac rehab. We kind of were that in between. So we're able to treat the higher acuity patients confidently. The patient themselves are able to get stronger, have the confidence that they're being watched oversight through 24/7, whether it be us and the outside monitoring company, while they achieve their prior level of function and leave here strong enough to attend a cardiac outpatient therapy and continue on towards their goals. I believe that is it.
Thank you, Kayla, and thank you, Dawn. I'd now like to invite all of our speakers to come on video and off of mute. And Grace, you can discontinue sharing the slides. Thank you. Awesome. Well, now we'll have our, thank you again for your presentations. Now it's time for our panel discussion and Q&A. As a reminder, if anyone would like to ask a question of our panel, feel free to do so using the chat feature within Zoom, and we will answer as many questions as we have time for. So during the presentation, we did get a question, and I think, Kayla, maybe this one starts with you, and then would love to get some insight from Dawn and Cindy as well. The question is, are your PMRs managing this, or do you have a cardiologist with oversight? And I think the question is, what is that physician or practitioner oversight of the program, and how do you work with to manage the responses to the alerts and alarms?
So we do have a cardiologist and his team that are in the building. So of course, if any alarm or issue that comes up with a patient, we bring it up to him. Him and his team are well-versed in Vios. So they'll look at the patient's history on it, and they will make their suggestions through there.
Awesome. Thank you, Kayla. And I know, Dawn, you've been working with your colleagues on thinking about how to implement a program like this. Have you had any consideration for how you would provide oversight of this type of program?
Sure. We have been in the fortunate position to have a group of cardiologists that are really anxious for us to get this going. So it's been reviewed with our medical director, and our plan is to have our medical director meet with the cardiologists as well, so we can come up with what's reasonable in our marketplace for coverage. As I'd indicated a little bit earlier, our medical director is a little bit concerned about the number of calls that might be there, what types of protocols, that the cardiologist team might have. So we're kind of a work in progress, but I'm looking forward to exploring it.
Excellent. And I guess thanks for sharing that. I think you mentioned it during your presentation as well regarding alarms and false alarms. And so,
Mhm.
Kayla, maybe you can share some of your experience and kind of the what Dawn is describing, has how are the alarms kind of showing up for you? Is it manageable, or are you doing things to make sure that you're managing them effectively? Can you share any perspective on that?
We try to be as proactive as we can. When I'm here, I round throughout the day to check anyone that is on and stay on top of whether it's batteries that are due to be swapped out, making sure that lead placement is correct. Our bedside nursing team, they're very good about, when they're passing down the halls, if they see an alert on whether it be, for a medical reason or such as that the lead popped off or the patient was disconnected, we try to address it as fast as possible with that oversight of everyone kind of keeping an eye on the telemetry.
I mean, think about the number of patients, Kayla. I think, one of the other things that comes up is you talked about kind of which patients you select, but on a day-to-day basis, I mean, how many total out of your 160 beds, how many total beds are actually, do you have patients that are being monitored? So, what's the volume that you're looking at here?
I would say on an average day, we at least have 4 to 6 patients on. And it
Okay.
fluctuates. If we get heavily hit with admissions, there's been days where we have had 12 patients on. If we're kind of in a lull and everyone's doing really good, sometimes we'll only have 1 or 2 patients on. It's definitely something that fluctuates. It's never overly consistent with, like, I would say just 2 people. It's definitely usually more.
Okay. So when you think about, I mean, I guess Dawn or Cindy, when you think about kind of clinical practice and a nursing perspective, um, managing maybe 4, 6, 8 patients, does that kind of help you think about it differently at all?
And so for me, that's kind of the number that we have envisioned.
Hmm.
We have the physical layout of the facility that we're looking at doing this has one hallway. Um, that's a short hallway that only has a few patients in it. So in our mind, we were looking at rolling out on this one wing in the unit. And so we were 5 or 6, and then
Hmm.
seeing how the need grows as we venture into the telemetry piece of it.
Excellent. Thank you. Now, Cindy, thank you again for joining us for the panel discussion.
Sure.
Um, when you look at um, the post-acute care space, and we have folks on this call joining from skilled nursing facilities and also inpatient rehabilitation facilities, obviously considering and investing in potentially a new capability or technology. um, what do you why do you think post-acute care facilities should look to make these investments, and how should they think about preparing for a change like this?
Well, I think we always have to keep growing. I don't think that there's a time that we should kind of rest on our laurels or just do what we do. So I think we always have to be thinking about what do our residents need. And I think with that in mind, always looking to providing the very best for our residents we really need to be saying, okay, we get a lot of cardiac people, or we get a fair amount. We're sending a lot of people back to the hospital. I don't know that we're doing them a favor by that. Is there something that we can do here? So I think we always have to be looking at that. I think we have to make sure that we're providing the services that are needed. And of course, that comes from investigation. That comes from talking to our partners, talking to our referral sources, looking at our diagnostic information in our medical records, like what is the volume that we have, and are we missing something? Um, are we not paying attention to those slight inferences, and can we do that better? So I think that there's a great opportunity for us to implement this. And Dawn mentioned it in her talk as well, is that yes, we want to take care of the resident, but it is a census builder, and it is a, a way to instill confidence in the community that this nursing home is capable of taking care of my family. So I can't imagine if I were in a situation right now where we had the opportunity and the need, as I've talked about, that I wouldn't be pursuing this, because I simply think it's one of the best things that we could do for our residents. Because the bottom line is always, what's the best care for the residents? I don't know if that answered your question, but that's my take on it.
Um, Thank you. Thank you so much, Cindy. I think that was a really helpful perspective. And Dawn, as a leader of, multiple facilities, um, how do you view and how does your organization view technologies? And how do you approach making decisions and what to invest in, and why should nursing homes continue to try and improve?
Boy, that's multifaceted. So number one, as far as the cost benefit of this, I'm lucky enough to work for an organization that'll has a department that'll take care of that for me. So I just get to look at the nursing piece of it. So I'm going to selfishly focus on that area. Um, just as Cindy said, we're we're taking these patients anyway. Okay, and we're always looking for ways to improve and make the experience better for the patient and also make the recovery better for the patient. And when we look at other types of technology, as a nurse, that's what I try to keep in the background is what are the things that we can do from a technology perspective that are going to benefit the patient, assist us in partnering with folks out in the community, whether it's cardiology, pulmonology, oncology. Our business development is pretty robust here in this marketplace. So they're continually asking, what are the things you need from us? And then it comes back to the clinical piece, and we work together to figure out, okay, we've identified a need. Now, how do we manage that need, and how do we be the best provider in our market for that particular need? So, and we're a technology-driven world, so 9 times out of 10, it's going to include some technology.
Thank you,
You know,
Don. And I'm
Joanne,
sorry.
could I add
Yes,
just a comment to that?
absolutely. Thank you.
I think too that when we look at technology, we have to look at what kind of labor does it save? Because having that telemetry on does afford us not so many vital signs taking, and I think that we need to be looking at our nursing time. And so by having that there, our nurses are actually going and doing what they need to do, and we know that it's accurate on the telemetry side of things. So you're not worried about the inaccuracies of perhaps having somebody different at different intervals taking those vital signs and things like that. So I think we're looking at consistency as well as maybe some safe staff savings as well. Don, do you agree with that, or are you?
Yep, I sure do. Taking into account, you know, if if the nurse is able to get a reliable set of vital signs and it's right there for her. That gives her additional time to do other parts of her nursing assessment, right?
Yeah.
And so, yeah,
Yeah.
it can be a time saver.
I mean, thanks for those comments because we're starting to get a couple of questions in the chat, and one of them is actually related very much to that topic, which is what is the nurse-patient ratio when caring for these patients? It kind of gets at that question of efficiency, and I think your comments were well taken. And additionally, Kayla, what have you seen at Momentum's facility with regard to the kind of nursing time and efficiency when it comes to caring for patients that are being monitored with Vios?
It has definitely helped our nursing staff. I know for one, the nurses love it when it's on because kind of like Dawn and Cindy had said, they look at the screen, they write it down. It reduces them having to, manually check everything, especially if it's a patient that may be critical or that we're keeping an eye on for whatever reason. It's just that extra level of oversight really has supported our clinical team and given them the confidence to treat and help these higher acuity patients, especially now that we have a cardiology team involved. It's been very beneficial for us here. And again, at the end of the day, like we want to reduce those hospitalizations, and it has certainly done that for us here.
Mhm. And I mean, I guess one of the other questions is then did you have to have any changes into the number of kind of team members, nursing team members involved in patient care, or was that stable and they just use the system to make them more efficient?
Yeah, I would say it was pretty stable for us. We didn't really have to change anything on that end. Again, kind of having the central monitoring station now on both floors and in the rehab gym, it gives us that extra oversight. So anyone kind of taps in when they see something.
Yeah, thanks. Any additional, thoughts, Dawn or Cindy, on that topic?
The thought that I have is that when I've been listening to Kayla and to Dawn and with Dawn saying, we're going to start out with this one unit and try it there. And Kayla, I know you mentioned in some of our preliminary talks that you have beds all over now that might have residents with telemetry in them, and hence you have three central units, or monitoring units, so that people can see things at different places. I think that's a sign of growth because I do think that we tend to start small and then move out. And I think that as we get more comfortable in that one unit, then we tend to think we can do this elsewhere. But I think that one of the main keys that both of these speakers have mentioned is the education and that consistent education. So you're not just training one nurse or two nurse, you're training your team. So your whole team really knows what to do and when to do it. And Kayla, you talked about interventions, and that's one of the things that I know that Dawn is working on is got to have a plan in place. When these things go down, we got to know what to do. And some of them might be individual based on physicians, but some might be based on protocols that your cardiology team or your physician team has put into play. Whatever they are, that's how you're going to prep, and that's how you're going to educate, and that's how you're going to care for these residents. But I don't know about all of you out in the audience, but in my mind, what a wonderful opportunity to be able to take these cardiac residents and keep them safe and help them get healthy and hopefully be able to send them home in better shape than they were when they came to us from the hospitals. So in my mind, we've met so many goals in utilizing this. Plus, and that's the care factor. And then there's those other financial factors that also play in. So I think as I look at it, if I were in a facility, I'd certainly be thinking about it based on what the facility census says. So just a thought.
Thank you, Cindy. And I think you touched on a couple other points that are coming up in our Q&A and some of the questions coming through chat.
Oh,
And so
sorry.
No, it's perfect because one about training, one about cost, and then one about documentation and EHR integration. So I would just say that, if anyone's interested in learning more about the cost of the system, you're more than welcome to reach out at viosmedical.com. We'd be happy to work on that with you directly, or you can make that request in the chat or through Cindy, and she will get you over to us for that conversation. But I think, Kayla, kind of in our preliminary discussions, you did discuss both your approach to training, not just the initial onboarding, but managing the ongoing training that naturally comes as you have turnover and change. And then, anything else that you might be able to share. I think Cindy and Don both kind of touched on the financial analysis side. If you have anything to share from your facility experience as well that you're comfortable sharing, I think our audience would love to hear about your experience.
Yes, so I mean, education is definitely a large component of it. Again, kind of like everyone had said, there is turnover in our environment. And that's kind of one of my main roles here is I'm constantly going over with new nursing staff the protocol for us here, how to properly place it on, what to look for if issues arise. If I see that there's a common theme going on, I'll re-in-service nursing staff and anyone involved. We also keep our rehab therapists very involved, again, because it does help us in the rehab aspect of that. It really has been astronomical here. I mean, between an increase in cardiac admissions because surrounding hospitals feel more confident sending their patients to us because we have this extra oversight versus, say, another facility that does not. Again, it has helped us drastically reduce rehospitalizations. And again, it really helped empower our clinical staff here. Like our nursing staff feels so much more confident treating higher acuity patients. And at the end of the day, you also have to support your clinical staff.
Thank you, Kayla. And then there's also a question about documentation. And I'll just provide, so um, the question is, are we able to print off reports and put them into the chart, or does it go directly into the patient chart? And, Kayla, we want to hear how you're doing it. I'll just share for the audience. There is reporting features where reports can be exported and downloaded. We also do have some direct integration with EMR systems that could be set up for automatic data entry into the EHR. We really work with each facility to customize the setup to their needs. But Kayla, maybe you could talk a little bit about the documentation and reporting at your facility, and then Dawn and Cindy would love to also hear kind of your thoughts on how you might approach documentation and reporting of this type of system.
So with the report system, how we kind of mainly use it, we have patients going to an outside cardiologist, maybe they don't necessarily use the one we have on staff here, we're able to print out reports to send with them, which has been very beneficial. Again, when you do just your average 12 lead, you only get a picture at that moment in time. You're not getting something that's drawn out over several hours or days, whatever the case may be. If we have an issue with the patient and the cardiologist or one of his team members is not necessarily in the building, we're able to go to the central monitoring station and print out exactly at that point in time whether that person went into AFib or whatever the case may be. And we're able to send it to them so they can see it right then and there. In terms of documentation, we don't have the setup here where it can automatically go in like Joanne had spoke about, but that is an option from my understanding.
Mm-hmm. And you kind of mentioned that your nursing team rounds and they just kind of work down and document instead of having to necessarily take that vital, they can just write it off the screen from the Vios system. So they might stick with their standard practices, but use the system to help support that when need be. Thank you. Don and Cindy, any thoughts from your perspective on documentation and reporting on a system like this and how it might be best integrated into workflows?
So I would think, and I've not used the system yet, so I would think that there would need to be a way to be able to select which parts of the data that you want to go into the medical record, because if you're on continuous monitoring, that's a whole lot of data to put into the medical record. So being able to make it useful, and whether that's and meaningful. So whether that's every time that there's some type of an issue, that would be something that's prioritized into the medical record. And then if it's, I don't know, once a day, a certain number of minutes of data, for the stable resident. I guess that's what I'm envisioning in my mind, not knowing what's available at this point for us to be able to do or not do. But the whole shooting match of ongoing, I can't imagine that all that data, would be helpful anyway inside the medical record.
Yeah, and I think that's what we see kind of from Kayla's experience, like many of our users. If it's automatically reported, that's obviously at predefined intervals. And then if there is an event, then that specific report is exported into the medical record. That would be event specific if something were to occur that you needed reporting on. So I see that we just have about 4 minutes left, and I want to make sure we get a chance to kind of get to our last question here and wrap up. So I have a closing question. Oh, sorry, Cindy, do you want to say something before I get to my closing question? Apologies. Thank you.
I'm sorry to interrupt you, but I just saw another question pop up, and I just wanted to quickly just share it. It says, thank you. We don't have cardiologists on site, so we are limited for sure. We've had an uptick in transfers out, so I'm exploring what we might do. And she said, it's excellent and inspiring work. Will you share these slides? So I wanted to just put that there, but I do understand what she's saying when she says that they don't have the cardiologists on site. But that's one of the things that I look to as that planning, like Dawn is doing, is getting a cardiologist, maybe not on site, but in a different place, having some means of communicating. Dawn, is that something in what you're looking at as far as setting up those things?
Correct. And I don't imagine that we would have a cardiologist on site, 5 days a week. What I'm envisioning is what we've done with some other programs potentially is working with the cardiology team on protocols. And then maybe they have a cardiologist who does weekly rounding, depending upon, their thoughts about that as well, whether it's, electronic communication with them, phone communication with them. But I think we do want to have some on-site, cardiologist within the building, like we've done with pulmonology and nephrology, et cetera. But the majority probably handled through protocols and via telephone or electronic.
And perhaps, Kayla, you could clarify, does your cardiologist, are they on site?
They're on site 2 to 3 days a week at least.
Okay. And then when they're not on site, how do you communicate with them?
Our clinical team will reach out to them, and they're always readily available.
Okay.
And
So
then
having physicians that you can reach out to,
Yeah.
or practitioners when needed.
Yep.
Okay.
Just another comment. Angela, the participant said, thank you. We're about 10 minutes from one of our major hospitals within our health systems. So perhaps there's something that could be worked out then if they're that close. My thoughts always go, because I live in deep rural Minnesota. And, the cardiologists are down in Minneapolis, or they're up in Fargo, North Dakota, or they're in St. Cloud. And so we don't always have them close to us. But again, there are ways that we can communicate and have some rotations. So I think that there's opportunities. I think that there is always a way. If you really want something, I think there's a way that you can work it out.
Well, and Dawn made an interesting point in her presentation, which these patients are coming to your facility already, right? The patients with this need. And so it's the information kind of empowers the local team to care for that patient and communicate effectively, whether that cardiologist is standing next to you in the room or 50 miles away in another town. So that's kind of one other way to think about it is, at least what I've heard from Kayla, is it's having the information to be able to have the conversation.
Yeah, definitely.
Awesome.
Sorry for interrupting.
No, thank you. Definitely. So I'd love to, I see we're at the top of the hour. I think just maybe one quick closing thought from each of you would be welcome. And of course, if anyone wants to learn more or has questions, you can reach out to Cindy. She'll get you in touch with us, and you can always visit viosmedical.com. But I think the question I'd ask each of you to just kind of briefly answer is, what is a lesson that you've learned when implementing new technology that you think our audience should consider when evaluating cardiac telemetry and continuous vital signs monitoring? So kind of one lesson from your experience that you think that this audience should consider as they walk away from this session. And Cindy, I'll ask you to go first.
Well, I think the most important thing is consistent and repetition in education, because a one-off doesn't do it. And with the turnover that we have, I think that constant re-education, readdressing, and then auditing, those are the two thoughts that I have, is that we can't get by unless we keep teaching and we keep checking. Those are, we have to keep checking that we're doing it the way that we're supposed to be doing it. And that's just part of our quality system. That's me.
Thank you, Cindy. And Dawn?
That's an excellent point, Cindy. The thing that sticks out for me is the times where I've stubbed my toe. So I am going to talk about, technology typically comes with Wi-Fi or internet accessibility, and making sure that your physical plant, your internet, is ready for the technology that you want to bring in. Because there's nothing worse than telling a nurse that you have them step on the scale, it's going to automatically upload into the chart, and then realize your internet bandwidth isn't sufficient. So can you tell I've done that before? So yeah, making sure you have the physical plant you need for what it is you want to implement.
Excellent. So working with the team to make sure it's set up correctly. Very
Yeah.
important. And Kayla, anything from your perspective, kind of closing thoughts on what this team should think about as they evaluate this new technology?
Yeah, definitely. Like Cindy had said, the constant education is always there, and auditing. Every month we sit down and go through all the patients, see where maybe issues lie, and then fix it moving forward. But in addition, it's very important to support your clinical staff. If they feel supported, they feel heard, they feel better doing their job, you have happier patients. You have patients that may come back if they unfortunately end up in the hospital again. And overall, it reduces rehospitalizations. No patient wants to be in the hospital for whether it's a few days or a few weeks and then come to rehab. And then, something happens that's possibly could have been mitigated with such technology that now they have to go back to the hospital. It really overall is just beneficial on so many levels.
Awesome. Thank you, Kayla. And thank you, Cindy and Dawn, for being with us today and sharing your experience and wisdom. And thanks to everyone for joining. Again, if you have questions, want to learn more, feel free to reach out to us at viosmedical.com or contact Cindy and she'll get you in touch with us. Thanks again.
Absolutely. Thanks, everybody.
Thanks, everybody. Bye.